Good afternoon to everyone who is here with us in person and also those that are here with us virtually. Welcome to the organ donation panel. We have a great afternoon with experts on all things organ donation and including health equity in terms of organ donation. Also, anybody who is online, we do have the Q&A, so feel free to put any questions, and anyone in the audience will have questions after all the panelists are done for today. First, I just want to introduce all of our panelists for today and also thank you all for being here. And also a big shout out to our Diversity Council team that made today possible. First, we have Dr. Swartz, who is our chief nephrologist for Mount Sinai South Nassau. Dr. Daniels, who is on her, oh, she's right here. Dr. Daniels, who is our attending physician in the palliative care division and also nephrology. Chaplain James Stewart, the director of our spiritual care services. Shanna Dacon Piera, who is the assistant vice president of corporate system affairs for the Office for Diversity and Inclusion for Mount Sinai Health System. We also have Nadia White, who is our nurse manager for our CCU and rapid response team. Karen Cummings, who is the manager of the community and governmental affairs for Live On New York. And we also have someone in the audience who, given the opportunity, will share with us their organ donation, organ recipient journey, James Aronson, who is here with us as well. And then we have Lena Hoyos, who is our manager for languages services and also for diversity, equity, inclusion here at Mount Sinai South Nassau, who is also our moderator for this afternoon. So Lena, take it away.
All right, everyone. So thank you so much for joining, those of you that are joining us virtually and also in person. We appreciate you being here. The Diversity Council worked very hard to put this together. And also thank you for you guys also for accommodating your schedules and making it possible for you to be here. So we're actually going to begin with Dr. Swartz. We're going to start asking questions individually with each person. And then please, if you have any questions, leave them till the end. If you are online, you can also type in the Q&A and we will get to it as soon as everyone is done. Dr. Swartz, when patients are referred to you, what diseases do you see more that are common that have caused maybe someone to receive your specialized care? Oh, they're mute.
The majority of patients that present to my office are typically diabetics. They also have hypertension, and a lot of them actually have both. They have hypertension and diabetes. We also see patients in my office for edema, swelling of the legs, as well as refractory edema where they don't respond to diuretics, and that's when the primary care physician will refer them to a specialist. We see patients with nephroliphysis, which is kidney stones. Then there's a syndrome called proteinuria, where patients may present with explosive edema of their lower extremities, and they have what's called proteinuria, which is protein in the urine. That's alarming, and typically a primary care physician, an intensivist, or family medicine will perform a urine analysis, typically a urine dipstick, and they'll see the protein. Sometimes patients will present and they'll say, "Doctor, I see foaming of my urine," and that's pretty alarming, and that might be a sign that there is an issue with their kidneys. There are times when patients are referred for kidney cyst, what we call renal cyst. Typically, they're simple or benign cysts, and we'll reassure the patients that these types of cysts are called acquired cysts. I can randomly take somebody off the street over the age of 50 right in front of the hospital, and if we randomly performed a sonogram, they would see cysts. Now, there are genetic disorders called autosomal dominant polycystic kidney disease, which is a genetic disorder which we would perform more of an extensive workup. We do see patients with kidney masses, renal mass. A lot of times, the primary care will either triage and send the patient to the nephrologist or a urologist. Typically, if the nephrologist, we deal with the medical aspect of kidney disease, feels that this is more cystic in nature, we'll refer the patient to a urologist who will probably work up the patient more towards cancer, malignancy. We see a lot of electrolyte disturbances, something called hyponatremia, which is low sodium, hypokalemia, which is low potassium, and also low magnesium, as well as all kinds of acid-based disturbances. Sometimes the patients come in from the community with these electrolyte abnormalities. A lot of times the referring physician will refer when they feel that these levels are too low, they're not comfortable. Typically, a lot of these electrolyte disorders are from medications. As we know, all there are medications and they have a lot of great beneficial effects, but all medications, including aspirin, have side effects. So a lot of times we'll work the patient up, reassure the patient that if we change some of the medications, modify that these electrolyte disturbances will be resolved. Within kidney disease, patients will present with what's gross hematuria, which is bright red blood, also disarming. And then there are times when they don't visibly see the blood, but when they see their primary care physician in the community, when they do a urine dipstick, they see microscopic hematuria where you can't see the blood or red blood cells, but they're there. And that's also something that the primary care physicians in the community are not comfortable with, and they will refer us, the patients to us. I think we covered.
Yeah, that was good. That was a great answer. That was no, thank you. Thank you for that. But at what point would you say that you would refer patients to a transplant center?
So a lot of these disease processes do lead to what's called advanced CKD, chronic kidney disease, and that's where we're talking. Chronic kidney disease, there are 5 stages. And again, most of these diseases, mainly diabetes, hypertension, some of these autosomal kidney diseases, lead to different stages. Now there's stage 1, 2, 3, 4, and 5. And then we consider stage 5, 6, end stage kidney disease where they require some kind of renal replacement therapy. When their kidney function is functioning at what we call an estimated GFR of 30 mLs per minute or less. In layman's terms, we could say less than 30%, assuming they have both kidneys, we will refer the patient for some kind of transplant evaluation. And we'll have to sit down and explain to the patient that when the level of kidney function is that compromised, it doesn't mean dialysis, but it means that there is a possibility, if there are no treatable or reversible causes or etaologies, that the creatinine clearance may worsen, which means the kidney function may worsen. And at that point, they should probably start the process of being evaluated for transplant, which is very overwhelming with patients when you hear that. Mm-hmm. And so we kind of have to kind of navigate them. Now, there are patients with a creatinine clearance of less than 30, and they're in denial. And they'll, say, doctor, I feel great. I don't understand why. And we'll explain to the patient preemptively, we just want to get the ball rolling so that you're in the system.
Right.
And this is not a last-minute assessment evaluation.
Okay, thank you.
You're welcome.
And how would you describe your relationship with the transplant center?
Sure. Well, we now have, this is now Mount Sinai, South Nassau, major tertiary academic center. Patients in the community now, they have access to evaluation locally. So Mount Sinai has a transplant program here in Hewlett area locally, where patients will be referred. We'll pick up the phone and call them. They can do most of the preliminary testing, any kind of test, and they'll explain to the patient that at some point, if and when they need a transplant, either a cadaver or living related, that the actual surgery would take place in Mount Sinai in New York City. Mm-hmm. It makes it a lot easier for patients as far as the workup. They don't feel they have to travel into the city, and it's not as overwhelming when they live in the community and they say, okay, we're right here.
Right. Okay. Thank you.
You're welcome.
And one last question is, what recommendations would you give members in the community to manage their health and thus avoid going into renal disease and ultimately failure?
Okay, sure. Again, the major cause of chronic kidney disease leading to end-stage kidney disease, leading either to a renal replacement therapy, which is dialysis, hemodialysis, or peritoneal dialysis, as well as home dialysis modalities, are diabetes, hypertension, and a lot of times both. In addition to overweight or obesity, we call the term diabesity, which is really not a medical term. It's really tongue and cheek. Patients that are diabetics and overweight. So a lot of the patients are overweight, and we will address quite good proper glycemic control with their primary care as well as endocrinologists, hypertension, blood pressure control, weight loss, and then in conjunction, healthy lifestyle, diet, as well as exercise. Now, the diet and exercise more towards the primary care, but as a nephrologist, we stress that in addition to why diabetes is such a devastating disease. It's called the apathies, diabetic nephropathy, which is kidneys, diabetic retinopathy, which is the retina, eyes, and diabetic neuropathy, nerve damage. So diabetes is not a benign disorder. And when the sugars are uncontrolled, we really need to let the patients know, please take this
Correct.
serious.
Mhm.
Serious.
Thank you so much, Dr. Swartz. I appreciate it. Nadia, as the role of nurse manager for critical care and rapid response, do you think you could walk us through the role of the critical care team and how it plays with organ procurement organizations, for example, Live on New York?
Sure. So the first step is identifying the patient. You know, when they come in through the ED doors or when they come to critical care, even if they're on the inpatient units, you have to ask yourself, is this patient a candidate for Live on New York? So how do we do that? We look to see if they're missing one or two brain reflexes. We also see if their GCS, which is called their Glasgow Coma Scale, is less than 5, which is a neurological test that we do. Then rapid response nurses or the critical care nurses and the ED nurses are all trained to do this, along with the physicians. It's not just a nurse's job, it's the physicians, the provider's job as well to help identify these patients. Also, if we're having an end of life discussion with the families, it's the perfect time to call Live on New York for a referral. So that's the first step. Once we've identified and called Live on New York, then they come in and they evaluate the patient. They touch base with the critical care team to make sure, you know, what's the status of the patient. Once that's done, they check to see if the patient is a registered or unregistered donor, and then we start evaluating the patient clinically to see if they are a candidate for organ donation.
Okay, thank you, Nadia.
Welcome.
How do you honor the patient and the family when the patient is an organ donor? I know that there's several individuals that are connected that are, staff members that are not aware. So I would love to hear a little bit about how that is done.
Sure, we do it in several ways, actually. One thing that the Live on New York team does is it's almost like a EKG in a bottle. It's kind of like their heartbeat is saved in a little vial, and they give it to the family members. And it's one of those things that's kind of like you're holding someone's heartbeat in their hand, even though they're not with you anymore, and they get to save it. It's really one of those things that I love when I see it. And, you know, you can tell it's very heartfelt to them. Another thing that we do is a honor walk. So what that is that the critical care team, and will be progressing to the whole hospital, comes together and we stand in front of everyone and line the hallways, and pretty much we say a statement. You know, we're honoring this person, whether it be your brother, sister, uncle, mother, son. In honor of this patient, we are here to give life to another person. So we walk in, we respect the family, the families are there, and they get to walk with them into the operating room.
Thank you.
You're
It's
welcome.
wonderful. If staff are interested in being involved with organ donation awareness here in Mount Sinai, South Nassau, what steps would you recommend for them to take?
First, they can contact myself. I am the Live on New York liaison for the hospital. We also have an organ donor council for the hospital as well, so you can definitely be a member of that as well. Dr. Daniels from the physician side works very hand in hand with us also, and Nicasia Jackson is our Live on New York liaison as well.
Okay, thank you so much, Nadia. We have our Chaplain James Stewart. Some of the questions that I'm going to ask you relate to religious or in spirituality, as far as religion and spirituality, and how sometimes those can be barriers to individuals in the community, and also, as far as, making the decision to be an organ donor. What are the religious opinions on organ donation?
So nearly all religious groups support organ donation as long as it does not impede the life or hasten the death of the donor. It's generally held that donation is for the benefit of others. So there is a sense of altruism or charitable act in saving or enhancing life. And so there generally is no action as it relates to a religious group's perspective on organ donation. It's usually assumed that donations are permissible. I know in recent years, some religious groups have taken a more proactive stance and have issued statements or resolutions or adopted positions, which encourages organ donation. And so that gives people the opportunity to plan and to consider the matter of organ donation accordingly. And with that, very few that I know religious groups actually oppose it. And actually, in recent years, organ donation seems to be growing statistically from a religious perspective.
Thank you. What are your recommendations if someone is unsure about their religion's view regarding organ donation?
Certainly, most religious groups tend to leave the decision of organ donation to the patient or the family. And so you want to definitely be in conversation with your family and to determine what it is you want. You also want to be in conversation with your religious faith leader, if you have one, to see if there are any noticeable opposition to organ donation. And so conversation with your family and your religious leader would be the ways to go and the places to start, and then make a determination from there.
Okay, thank you. And just one last question. I wanted to know, what is your team's role in the past? What has been your team's role in regards to an organ donor, family or an organ donor recipient?
So yeah, I'm grateful that Live on New York has spoken to the chaplaincy department here over a number of years, and so we have a critical part with family. We are often consulted by family. I can remember a number of cases over the years where families reached out to me and was like, "I need your opinion," and they have been from opposite religious
Mhm.
backgrounds, and so I was always humbled by that. Obviously, the first thing I would say is you need to be consulting your faith leader, but I just tried to be present and just walk the journey with them to see what it is that they want, and they valued that perspective, and so it was great for me to do that. And so we're often when we have family meetings, spiritual care services are involved. We often field questions about it, which is one of the reasons that we have Live on New York come and speak with chaplains, so that at least there's some awareness of conversations that we can have. And so it's helpful to be a part of those family meetings and part of those conversations. And so there's a number of instances in which we have consulted families over the years regarding organ donation.
Thank you so much, Chaplain James. Dr. Daniels, with organ donation and transplant lists, do you see opportunities of improvement in terms of equitable access for all?
Thank you, Lena. Yes, definitely. There are a lot of opportunities for improvement. And, at a grassroots level, at a community level, we as healthcare workers are in a unique situation. We, um, we can help raise awareness among community members. We can work with churches, synagogues, temples, mosques, etc. We can address common myths and misperceptions among family members, people in the community, and we can really have a role in um, in addressing, in reversing or mitigating healthcare disparities. As critical care providers, also, we are in the unique role of clarifying issues like brain death to the family members. We need to be sensitive. We work very closely with spiritual care, and we're very sensitive to religious and cultural views about organ donation. And we're working as a community of healthcare workers here in the hospital, but also outside. But on a larger scale, I do have to say that the medical community and Dr. Swartz and I and other people in this field, transplantation, nephrology, it's very exciting to see how the medical community has stepped up over the last few years since 2020. One of the big moves that the medical community made, the ASN and the American Society of Nephrology, National Kidney Foundation, they removed race from the calculations of renal function. In the past, race used to be in the calculations, but race is a social construct. It's not a biological determinant per se. So that's now gone, and there are new equations that are being used nationwide that exclude race. And another index that had been used for many years, the kidney donor, it was the kidney donor um, risk index. This was used to figure out whether a donor would be a good donor or not. That also included race based on observational studies, but that's gone as of within the last few years. Race is now gone from that equation. And lastly, I think the fact that the Accreditation Council for Graduate Medical Education is promoting end-of-life education among all residents, we have an opportunity to include organ donation and, you know, to educate people
Okay,
more.
thank
Those
you.
are opportunities.
Thank you. Barriers to transplantation in communities of color. Can you tell us a little bit more about that?
Yeah, there are a number of barriers that I've discovered exist, and I gave a talk a few years ago at one of our, you know, in-house lectures about which included barriers to transplantation in communities of color. Of course, we know about the socioeconomic factors, but there's also a lack of knowledge among regarding donation among people, and it's been shown even in other countries, like in the UK, that um, that ethnic minorities have less knowledge, sometimes 80%, 60% less knowledge than white populations in their countries or here. I think here it's about 80% less for people of African ancestry, maybe about 60% less for people of Hispanic or Latinx ancestry. Another barrier is that in many cultures, people don't want to talk about death, so they don't talk to their families. Then there are concerns about faith. Reverend Dr. Stewart addressed some of that. Trust in doctors and the healthcare system. There's some communities who feel that we will steal organs and that people will not get the same level of care if they're registered as organ donors. And one of the barriers too is physician hesitancy or lack of knowledge, particularly in underserved communities where the physicians are overwhelmed and they don't have that knowledge about organ transplantation. They're not able to advise the families and patients who might be looking for information. So those are some of the barriers.
Okay, thank you. Why do you feel it is important to address these disparities seen in organ donation regarding the community and people of color?
Right. Well, if you look at the information that's available from the office, the U.S. Department of Health and Human Services, the Office of Minority Health, if you take communities of color, take people of African ancestry, 13% of the population in this country, but 28% of waitlisted patients awaiting a transplant, 28% of waitlisted, but only 12% of organ donors. If you take the Hispanic community and this particular office, they classify you as Hispanic. They don't really talk about Latinx, et cetera. But they're 18% of the population, 20% of the wait list, only 14% of donors. So there's a discrepancy there. Similarly with Asian populations as well. And again, they lump East Asians with South Asians. Asians are only 3% of donors, but they are 8% of people on the wait list.
Wow.
So those are some of the reasons that we need to step up.
Correct.
Yeah.
Since kidneys are the #1 organ needed, on a donor list. Do you see any disparities in access to transplantation for patients with chronic kidney disease?
Um, yeah, yes. And again, I've looked into some of this. I mentor a medical student who is looking at financial disincentives faced by living related donors, financial disincentives faced by kidney donors. And it was shocking that if you are a kidney donor, 20% of donors, living donors, pay more than $5,000 in out-of-pocket costs. I mean, think about, spending $80 in parking going into the city, you know. Fortunately, we now have we have access to transplantation evaluation here. So, and more than half of those donors are spending over $1,000. So that's one of the financial disincentives. And then there are issues like finding a living donor. If you are of African ancestry and you're trying to get a donor among your family members, there's a good chance that your family members are afflicted with diabetes, hypertension, and etc. So if you take a Black patient who has end-stage kidney disease, a Black patient with a first-degree relative with end-stage kidney disease, that's a sibling, parent, child, they're at a ninefold risk of having end-stage kidney disease themselves. So
Wow.
these are some of the things that are the odds that are stacked against communities of color when, even access to living-related transplantation.
Well, thank you so much, Dr. Daniels. I appreciate it. Thank you. Next, we have Shannon Dakin Pereira. A couple of questions for you. How does culture play a role in someone making the decision to become a donor?
Yeah, definitely. So when we think about culture, we think about these shared values and belief systems that a group of individuals has. And when it comes to organ donation, I think much of what was referenced in terms of beliefs around death and dying, or even the discussion amongst families around that and beliefs that exist. Some cultures don't have the conversation around that, or they don't want to think about death and dying. And certainly, when you're thinking about organ transplantation, you know that the patient is in a position where that can be a possibility. And so that serves as a barrier. I also think, there are some cultures that, really don't believe in, making incisions on the body in any way.
Mhm.
And so, for individuals that belong to those cultures that have those beliefs, they are hesitant to become a donor because they don't want to disrupt the body in any way. I also think, in terms of, especially when I think about African Americans and Black families and the trust that Dr. Daniels referred to, we think about the historical and generational trauma that has existed, particularly in this country when it comes to being operated on and being tested on, and, the experience that Blacks and individuals of color have had in the medical community. That also plays into their own cultural beliefs, and it gets passed down generation to generation, that families just don't talk about it. So I think those are the ways in which culture can certainly impact a donor. And so if you were to speak to individuals like, hey, do you want to be a donor? And they have all of these things in the back of their minds, most likely their response is going to be, maybe not. I don't want to consider doing that for myself.
Thank you. And one more question. What social determinants of health impact minorities to seek healthcare?
Right. So social determinants of health, of course, are these conditions in which we live, work, grow, and age. And so, again, I think a lot of what was referenced, thinking about economic stability. If an individual doesn't feel that they can manage the financial burden, if they don't have health insurance or access thereof, they may be reluctant to become a donor. If they don't have access to a healthcare facility that is near them, they may not be willing to seek out the information themselves to learn about what is really entailed in organ donation. access to education. I think that's foundational both in cultural beliefs and practices, and also when we're thinking about barriers to care that are posed by social determinants of health. If they don't have access to the education around transplantation and what that really means and what is entailed, that also serves as a barrier. When I think about other social determinants of health, certainly the Centers for Disease Control lists racism as a social determinant of health as well. And so again, the interactions that marginalized communities and people of color have had in the medical environment, if they have not been good interactions, if they have been in situations where they can't trust their doctor, or they're not used to going to see a physician regularly, then they can also be reluctant to sign up to be an organ donor. So those are the ways I think social determinants play a role.
Thank you so much, Anna.
Sure.
Karen, can you tell us a little bit about Live On New York and the role that you play with our organization here in Mount Sinai, South Nassau?
Yes. So Live On New York is one of 56 what is called OPOs, or organ procurement organizations, across the country. We are not for profit, and we are federally designated specifically to facilitate all the life-saving transplants in the New York metro area. So from Long Island to Poughkeepsie is our service area. In addition, we have a small area in Pennsylvania, because the nearest hospital is actually in Orange County, New York. And we handle everything that has to do with organ donation within that service area. We are the largest in New York State. We have about 70% of the state is where we service about 13 million people. And our goal is not only to save the lives of the thousands of New Yorkers that are currently waiting, but also to support their donor families that at the worst time decided to give the gift of life for their loved ones. So it is our role to really facilitate all those life-saving transplants.
Thank you so much, Karen. Are there any specific statistics that we would like for the the people here that are attending to know that are significantly, affecting the need for organ donation?
In our area, it's really critical. And I think it's important for everyone to know, Dr. Daniels kind of talked about it, but about 75% of people that are waiting in our service area are people of color. And unfortunately, where New York stands, we stand towards the bottom of the list as far as our number of residents who have said yes to being organ donors. So we have about 45% of our residents who are registered, and most states have over 60, which means that if you're in need of a transplant in our area, you tend to wait twice as long as every other state in the country. So it definitely affects our communities of color, but it really affects everybody in our area that are in need. So our goal is to not only encourage people to get educated about organ donation, but then to take action and then to tell their families.
Thank you. And last question, what are the measures taken to ensure that organ harvesting is possible?
We don't like to use harvesting, by the way. We use procurement.
Procurement, okay.
The measures that we take to make sure it's done properly, well, there's laws in place for us that affect us in every aspect of organ donation, from registering to how we procure organs, to our process of working with the hospitals like you guys to make sure that every donor is respected and every family is honored.
Mhm.
So we have all that's in place. So we do that in every case that we facilitate with every hospital across our area, including Mount Sinai.
Okay, thank you so much. Thank you, everyone, for answering all these questions. I'm now going to have two individuals share a story. The first one is going to be our very own Shanna Dakin Pereira from the Office of Diversity Inclusion for the Mount Sinai Health System.
Sure. I don't know where to get started, I guess at the beginning.
At the beginning.
So, again, I'm so honored to be part of this panel because it's the first time I've actually shared my story in such a public forum. But, I was getting a bit emotional, hearing Dr. Swart speak and hearing Dr. Daniel speak because I am an organ recipient. I received a kidney from a live donor, my cousin, almost 6 years ago. It'll be 6 years in May. And, I just think about all the things we've spoken about on this panel and how that has impacted my life in terms of that journey. So I was diagnosed, I guess you could say before birth, at birth, with polycystic kidney disease. So I've, had, polycystic kidneys throughout my childhood. Technically, I still have it, but it was the reason I eventually needed a transplant. And actually, it's interesting because I received it from my father, who actually did not know he had it until my mom was pregnant with me. And it goes back to these sorts of things are, at least in Black communities and Black families, where we don't talk about our health in this way, and we don't share, on those forums where they ask you, what is your family history? I've had to ask questions to my parents, like, what is our family history around this? How did this come about? And so, he found out when I was born, and of course I had it, and have been going to nephrologists since birth. And so the nephrologist almost became my primary doctor, even though I had a primary care, because it's just something I've always had to follow up with. It got to a point back in, I had my transplant in 2017. So it got to a point about a year or two before that, where my nephrologist said, we really need to look into getting you on the list. Because some of the measures that we heard discussed, my GFR, my creatinine, my creatinine was increasing, my GFR was decreasing, and it was at a point that I really needed to consider transplantation. So in 2016, I remember going around considering dialysis options at that point. I looked into peritoneal dialysis. I looked into hemodialysis. Both terrified me, to be quite honest. But it was a reality that I had to face because my kidney function was decreasing, and I actually felt it. I felt tired. At the time, I was commuting in person to work every day. Of course, this is pre-COVID, so I felt it in my commute. I felt very tired. I felt tired at work. And so I saw the effects and knew that it was something, a reality I had to deal with. And I remember a conversation with my nephrologist. He said, is there anyone you can ask to donate a kidney to you? And thinking about my family, I said, well, no, nobody's going to want to donate a kidney to me. Obviously, on my father's side, this is something that, is genetic. So there are several of my uncles, including my father, who my own father had to have a transplant. He actually had to do 2 transplants. But, that line was not a possibility. I was nervous to ask my mother's side of the family because my mother has some other conditions of her own, and so I just figured, they're ruled out. Again, much of what you were saying, Dr. Daniels, about like some of these genetic disorders, they permeate in families. So that was a difficult conversation. And he said, well, what about your faith community? And so I was thinking about, my faith community. Well, do I want to ask anybody in my church? And again, these are not things we are used to discussing in those communities. So I said, well, no, I don't need anyone at church knowing I'm going through this. So no, I don't want to ask anybody at church. And so it was really, I started thinking about those stories where, people are posting on Facebook, they need a kidney or they need another transplant. And I'm like, well, that's not a possibility for me. I don't feel comfortable doing that. So I really feel that I had no options, and I was really just relying on the list. I remember getting a workup to examine my veins. I decided on hemodialysis, so I got the workup. I was, literally had the surgery scheduled for the beginning of 2017, and I was on the bus one day commuting home from work. And I shared this story with Karen and Lena and Amber, so they know. But I was literally on the bus coming home from work one day, and I said, you know what? I say it's the voice of God, because that's my belief. But he said, ask your cousin. Ask your cousin. Now, again, very close with my family. My cousin, who ended up donating the kidney, is just 10 months older than me. So we've always been close. We've grown up as sisters. And, but I hadn't shared any of this with her before. And so at least she knew I had a kidney issue, but she didn't know the extent of it and where I was in terms of my treatment. And I literally sent her a text and said, you know, this is a situation. I'm facing hemodialysis. I'm terrified. You know, would you consider being a donor? And literally right away, she responded. She said, you know, I've been looking to do something like this. I had a friend who just donated an organ to a loved one, and I've been looking to do something like this for my life. She said, of course, I'll get tested.
Wow.
And it was amazing. It was the best feeling in the world. And it so happened she got tested because, again, that's only one battle, right?
Right.
Making the ask. They have to match.
Mhm.
If she wasn't a match, then this would not have worked. So, you know, she got tested, and I think it was like a week before I was scheduled to do the surgery for the fistula for hemodialysis that she found out she was a match.
Wow, amazing.
So cancel the surgery. Very happy to cancel that surgery. And you know, we did the necessary workups. You know, she it's funny. They told her she needed to lose weight for the transplant, and she like got right on it. We did it together. Yeah, they said she had to be within a certain range, and she did it. And
Wow.
I did it right with her. And my birthday is May 5th, and my transplant was on May 9th.
Wow.
So, and my aunt's birthday, her birthday is May 10th.
Oh my goodness.
So
Wow.
May 9th, of course, we're in the hospital. You know, did the transplant surgery. Everything obviously went well. You know, and May 10th, we were both in the hospital celebrating my aunt's birthday from the hospital bed. But, you know, it's been such an amazing journey. And, you know, one of the other things I'll just reference, at least for me, because I felt I had no one to talk to about this,
Mhm.
at least within my immediate family system, because he didn't really understand what I was going through. My friends didn't understand what I was going through. My primary care physician recommended therapy to deal with the anxiety.
Mhm.
And, you know, therapy is another one of those things that's, you know, at least in minority families, is
Right.
typically looked down upon.
Mhm.
People, you know, think, oh, you're crazy for seeing a therapist.
Right.
You know, why are you going through that? But I have to tell you, it helps me a lot. It helped me deal with the anxiety of going through this alone, well, seemingly alone,
Right.
in terms of my experience. It helped me even deal with what my father was going through. My father had a very difficult time. And I won't go too deep into his story, but he received the transplant first from a deceased donor, and it didn't go well. And so he ended up receiving another kidney in 2018 from one of my uncles that didn't have you know, the polycystic kidney disease, and that did go well, but he had a difficult time. And so at the time when I was going through, you know, preparing to receive my kidney, I was thinking about his experience that hadn't gone so well, and I was terrified about that as well. But therapy really helped. It helped to talk it out with someone. It helped to have someone there that I can express and get my feelings out, and who made me feel validated in those feelings, but also said it's going to be okay. Your story is not necessarily his story.
Correct.
So, you know, everything went well. You know, of course, yes, I am on transplant medication for life. And, you know, that's part of what you live with, getting a transplant. But I tell you, I will trade that, you know, for anything rather than being hooked up to a machine. But dialysis is, I mean, you know, for those who do go through it, I have an uncle who is on dialysis now. My father went through it, and it is still a life-saving procedure as well. And so even if I had to go through that, I'm glad that I had, you know, people in my life who did go through it and could walk me through it. And that's the most important thing, the education around it, the ability to have people in your life who go through it. You know, there were support groups that My transplant center referred me to talk to others who were living with, kidney disease and were going through dialysis. And if I needed that support, I can talk to them. And all of that was really helpful in terms of making sure that my story was a success.
Well, thank you so much, Anna, for sharing this story. And I think one of the things that you mentioned that, we haven't talked about and that people do hesitate to talk about, especially in minorities and people of color, is therapy. And whether it's a social worker, a counselor, or a psychiatrist, psychologist, people are very hesitant. So thank you for bringing that up and thank you for that story. That was amazing. Thank you. And we have one more speaker. We have James Aronson. You can come up to the podium and share your story as well. Oh.
So, party started.
You can use the microphone, James, so they can hear you.
All right. You can't, nobody can hear me? Of course you can hear me. So my story is, first I want to thank everybody, after my hug, that was first. Second, I want to thank everybody up here for what they do and what they are going to continue to do. People like me who are a recipient, I am not a kidney transplant, I'm actually a heart transplant. So my life was completely changed, completely different, and completely saved because of what these people do. So thank you so much to them. And those of you out there who do this as well on the screen. So my listening to Shauna speak, my story is so similar and so different from her story. And I mean, it's a different organ, first of all, but I was a very an athlete my whole life, right? I was a little kid athlete. When I was 17, I went to find out, I went to join the Marine Corps, okay? And I get there, and my birthday happens to be November 10th. And November 10th happens to be the Marine Corps birthday, right? So I go in there and they're like, hey, do you know that your birthday is a Marine Corps birthday? I'm like, no, like, you're born to be a Marine. I'm like, born to be a Marine. I'm like, yeah. So I'm ready to go. And this is the kind of person I am. I'm out there. I'm not going to say I'm loud, but I'm not shy. I'm an outgoing person. So I actually, believe it or not, I failed the physical. I'm like, how am I failing the physical? I'm very athletic. I played sports in high school, wrestled a lot. Ran a lot, in very, very good cardiovascular shape. Heart anomaly, go check it out, which I didn't do, of course. But I knew that there was something with my heart from that age. I had no problems, nothing at all until I was, one day I went to go get a stress test, and I'm almost 40 at this point, late 30s. Go to get a stress test just to get it, and they say, hey, listen, your heart only works, your ejection fraction, for those of you who don't know, is the strength of your heart, and have the output only works at 33%, and which is not good. And I'm like, you got the wrong guy. I'm a competitive bodybuilder. I'm a competitive kickboxer. This is what exercise is my life. Fitness is my life. And I have no restrictions. I feel fine. No, they had the right guy, obviously. At that point, I didn't go on any medications at all. They said, they said, you're going to eventually, and they said within 5 years, probably need a heart transplant. I'm like, all right, whatever. You guys don't know what you're talking about. Within maybe about 2 years after that, maybe even less than 2 years after that, I started having symptoms. And my only symptoms were breathing. And I remember I was for a very long time, about 30 years, I was a DJ. Not a DJ, an MC, the hype man at the party. Put your hands up, let me see you get crazy. I'm that guy. So I know it's hard to believe. I know. So I'm at a party and I'm really out of breath. And I'm like, wow, I can't believe, like, I'm so out of breath. I do this, I do this 3-4 times a weekend. Anyway, so I go to the doctor and like, yeah, well, your EF, ejection fraction, is now 25. And it's going to go and it's probably going to get worse. And I'm like, okay, what do we do? I get on some medication. I go to Columbia Presbyterian Hospital. I get into the transplant, I would say in the transplant building. My doctors are now transplant doctors. When I go to get my regular checkups, I go to transplant doctors. But again, the breathing came and went when I got on the medications. No problem. I was feeling good. Eventually, over the next couple of years, my ejection fraction had gotten down to 15. And I'm still doing this. This is me. I'm still lifting weights. I'm still competing. I'm still I'm not kickboxing as much because I'm on blood thinners, and the blood thinners I can't. I'm training, but I can't get into fights anymore. So at least I didn't do that. But interestingly enough, I didn't have to have any of these conversations that Shauna had to have. Listening to her. I'm like, I'm shaking my head. I'm like, God, that's so. I would be. I wouldn't feel comfortable in any way having a conversation like that with a person asking me for not a heart, of course, but in anything like that. So I applaud you again for that. So I would probably cruise at 15% for about 8 years, maybe 8 to 9 years. And again, doing my thing, no symptoms. And then about early 2021, let's say January of 2021, then I started really breathing poorly. Again, only during exercising and work and doing my parties. I could just walk around normally, normal person. Anyway, my EF had down to 10. All right, so now I'm walking around with a 10% EF. Still lifting weights, still doing my cardio, still. And again, I don't claim to be the smartest guy who ever lives, but yeah, I'm like literally lifting 500 pounds, and I feel my heart just complaining, cramping up on me, and I'm like, come, what do you got? Bring it on, bring it on. And I'll put on 10 more pounds now. With my cardio, I had to do a cardio, an hour of cardio every day, mentally. I had to do it. I had to do it. I could only do about 10 minutes of cardio before I had to get off the machine. So, because I couldn't breathe. So I would actually do 10 minutes, get off for 2 minutes, get back on. But it would take me 2 hours to do 10 minutes of cardio. The reason I say this is because um, I was foolish, I guess, but also maybe a little bit reckless, but I was determined. Whatever I have to do, I'm going to do to keep myself going. And I didn't have to. I avoided a lot of things that people, unfortunately, who get heart transplants have to go through. They put you on a, I don't know, most of you must know, it's called an LVAD. It's a vest, and what it does is it's two batteries, and it pumps your heart for you, and from what I understand, it's not a good experience, and you have to do that until you get the new heart while you're waiting on the list. I was never on a heart transplant list because it doesn't go by, even with my ejection fraction at 10%, because again, you would look at me just like this, and I would look just like this. It goes by, thriving or failure to thrive. So I was still thriving. But I did speak to my doctor, and she said, in the city in Columbia, and she said, you're gonna have a sudden event, and it's gonna happen, and it did. So that day I was lifting weights, shock, and I start breathing very, very poor. I mean, worse than I had been breathing, really, really badly. Okay, so I actually did cut my workout short. Go home. That was probably 8 o'clock in the morning. I go home, and all day I'm breathing like all day. And I've done that many times, but it's always gotten better. This time it didn't get better. Now 6 o'clock at night comes around, and it's actually starting to escalate. And I tell my wife, I'm like, listen, I think you should call the ambulance because I'm not going to be able to talk in a minute. And I knew it was just getting to that point, and I couldn't. I mean, and again, not to sound like a tough guy or anything like that, but I was never scared of any of this. None of this scared me. Maybe it should have scared me. Maybe I wouldn't have lifted that 500 pounds. But when I was lying on that, or actually sitting up on that gurney in my house as they're taking out of my house, and this is all I could do. I'm like, I'm gonna die right now because I cannot even get this much air in my lungs. So I'm gonna die. All right, and that scared me. I didn't die. I woke up the next day in Columbia Presbyterian Hospital. They were ready for me. They knew I was coming, and I woke up on an ECMO machine. If you don't know what that is, I'm sure. Well, you all know what it is, but it pumps your heart and your blood for you. And they got me a heart within 8 days. So I was so blessed. And what Reverend Stewart here said earlier, he referred to being grateful that you were talking to some people and they came to you even though they were outside of your religion. When I woke up, I had this overwhelming feeling of just gratefulness, and it wasn't, I it was a tangible feeling. It wasn't like, oh, I should be grateful now because I got a second chance. It was just there, and I'm in the hospital. I'm in bad shape. I was in the hospital for almost 5 months. I rejected twice, septic twice, 2 blood infections, 2 other infections, fungus in my chest, the doctor said you had just about everything a person could have as far as side effects. But I had everybody, all the nurses and all the doctors, God bless them, they're like, you're so strong and you have such a great attitude. I'm like, listen, all I'm trying to do is wake up tomorrow morning. That's all I'm trying to do. If that makes me strong, then I'm strong. You know, the reason I have a good attitude is because I'm grateful, and God blessed me with this, and blessed me with this strength. I know why He made me so strong and so stubborn. You know, it all makes sense. It's not even a question. You know, and just the other day, I was speaking at Lij. I've done this a few times, and you know, maybe a handful of times, and it's wonderful. It's amazing in every way. But I was speaking at Lij, and it was an amazing thing. And a pastor came up to me and asked me this question, which I get this question all the time, and I'm sure, Shana, you must get this question all the time as well. He said, "Do you ever ask why you?" I don't know if you ever get that question. Why you? Why you? And I have a standard answer, or why me is the question, right? You ever say to yourself, why me? And I have the standard answer to that question that I always say. And the answer is, why not me? You know, who am I? Why the 7-year-old I met the other day who got a heart transplant? Why her? But as the words are coming out of my mouth, because they almost come out automatically at this point, God said to me, and this is like when you said you thought you heard the voice, I know I heard this voice, the voice, and you did hear the voice, by the way. Said to me, that's not your answer. Your answer is, I chose you for this. You are my vessel. You are I gave you I made you strong enough to do this, but I knew you were going to come out like this on the other end and talk to people and absolutely ask people to donate and become organ donors and say, look at me, I'm the guy. I'm the guy you saved, because of people like you and people who donate are the reason that I am here. So you saved a life. I wouldn't change it. I wouldn't change it at all. This is what it is, and now I know why I was chosen, and this is what my path is in life because he gave it to me, and it's amazing. So if you don't take anything out of this other than this guy had a story. Gratefulness is the key to happiness, and gratefulness is the key to life. It really is. So now I get to do everything I do. I don't have to do anything. I don't have to go to work. I get to go to work. I don't have to speak today. I get to speak today. I don't have to go to the gym. I get to go to the gym. Everything, I get to meet all these amazing people today, because God blessed me with this heart transplant. So thank you.
Wow, what an amazing story. I think we learned a lot today from all of our panelists, and then also from the individuals who share their personal stories. Thank you so much for doing that with us. It was an honor. And again, I think, God is amazing, and that He did that for both of you. So thank you. Is there anyone in the audience that would like to come up and ask a question to any of the panelists or any of the two individuals? Anybody? Oh, yeah, you can come up. You have to just come up, or you can tell me and I can. Or anyone also on Teams, if you'd like, you could type the question in the Q&A.
I'm working at the dialysis center, patient, the South Nest, Mount Sinai. I was so surprised, patient waiting the period for the New York is 7 years, but the surprise, you have like 8 days. So any particularly different organ and the waiting period, anything to, anyone can give the answer? It was amazing. I can't believe the 8 days. So let's say liver transplant, how long usually average, the waiting period? And the kidney 7 years, different state, like a less, the period. So let me know if anyone can give the answer. Thank you.
So go ahead, Karen.
I mean, 7 years is mainly because kidneys is the largest need. So it's about 70% of the list of people who are waiting just for kidney transplants. So that's probably it. But liver is a close second. It really depends. You're up on the top of the list because you need that organ as quickly as possible. You're the sickest. So those are the people that are going to get it the quickest. So in James's case, he probably was the sickest. That's the reason why that wait time was so short. But I mean, when you go and list yourself, they do give you an average waiting time, but if you get sicker, your doctor will recommend that you move up on that list so that your wait time is shorter, just because your need is so great. So that's.
Thank you. I appreciate it. Thank you. All right. Anybody have any other questions in chat or in person? Rita, come up and you got to.
I just want to know, what can we do in minority communities to get children and parents, young parents, to how can we support them in getting the access they need and regaining trust in healthcare to be able to fight the risks of diabetes and hypertension that lead to this problem? What can we do? How do we ramp up our efforts in those communities?
Shannon?
And like,
Yeah, so that team's good.
Right. So I believe the question Rita asked was, what can we do to educate families and children about, to prevent the risk, essentially, that lead to the need for an organ transplant in the first place. Right.
So many of those social.
Absolutely, absolutely. And I think it starts with the education, right? It seems like such a simple answer, but it really does start with the education and also going to where people are. So, a lot of times, we do health fairs and other things here in the hospital, but maybe everyone can't come to the hospital. So do we need to go out into the actual community where they are to do a screening, to do these tests? Maybe we need to have a block party in some community, something that they're familiar with to bring them out, to pass the education on that way. So what are some unique and out of the box ways that we can share the education, meeting people where they are so that they get it in the ways that they're used to? I think that's one of the best things that we can do. And also I think it's what we're doing today, sharing our stories. Because once we're able to share our stories, people know that it's possible, that, okay, I see why organ donation is important. I see the need for it. I think it also, storytelling is powerful. And so people telling stories about, not just organ transplantation, but, dieting, eating healthy foods, making healthy foods. A lot of the things also I think we overlook is, especially in ethnic, racial and ethnic minority communities, when we give discharge instructions from the hospital, we're telling people, oh, diet this way, eat this food and eat that food. Are we paying close enough attention to what they're used to eating at home? And how does that fit into the diet plans that we're giving them in the discharge information? Is this something feasible for them? We sometimes don't ask those questions. And so delving a bit more into, okay, what is the closest food store you have access to? Can you get these healthy, foods to eat? And if you can't, what are ways that we can help you gain access to that? Or, can we set you up with a nutritionist to go through some recipes that may be more familiar to you so you can work this into your diet plan? I think delving more into those forms of education is also the way that we get to prevention, but also just overall awareness about, the things that we're recommending.
Thank you, Shannon.
Well, I'm glad you brought that because, Town of Hempstead has worked with us with the mobile vax.
The mobile vax.
Deal, and now it's going to be a mobile health unit. But I think we're heading down the right road and really bringing education to the people.
All right.
Thank you for that.
Thank you. Any other questions? Okay. Thank you so much for joining us and allowing for this to happen.